All right, we're going to show you more about the musculature of the abdominal wall. Let's orient you again. The patient's head is up here. That's the xiphoid process. Patient's feet are in this direction. That is the pubic symphysis. This is costal margin. This is inguinal ligament. This is a midline incision, or midline mark. We've shown you the right subcostal incision. We've shown you the inguinal incision and the anatomy of the inguinal area. What I'm going to do now is make a midline incision. Then we're going to reflect the skin and subcutaneous this way to show you the entire musculature on this side of the abdominal wall. Now when I make this midline incision, you're going to notice I don't want to go directly through the umbilicus. That would be unsightly, so I'm going to want to go around the umbilicus. And surgeons typically go around the left side of the umbilicus. There's a reason for that, and I'll show you when we get there. But let's start with this midline incision, going right down the midline, curving it around to the left of the umbilicus, and then following the line right down to the pubic symphysis. And I'm going to cheat a little bit just so I can know what my depths are. And the reason we go to the left of the umbilicus is there's a structure inside the abdomen called the obliterated umbilical vein, which travels in a structure called the ligamentum teres. And that structure is a little bit to the right of midline. And sometimes that structure is still vascular and you don't want to get into it. So you go around to the left side of the umbilicus to stay away from the ligamentum teres. I'm just elevating the skin and subcutaneous tissue from the underlying muscular tissue. And since I happen to be on this side, because filming is a little easier, I'm going to go right through the umbilical stalk. I don't know if you'll be able to see that or not, but we'll go right through the umbilical stalk. I would not do that in a patient unless that patient had an umbilical hernia. But we'll see what we've got to see there. Again, all I'm doing is elevating skin and subcutaneous tissue from the underlying fascia. And we're going to do this until we get the whole thing peeled back. Getting some resistance up here because of a prior incision scar, but it's coming back nicely now. Got through the fascia a little bit there. Let me go back and get a little bit better plane. And here you have rectus muscle in the middle. You can feel the edge of rectus muscle right here in a muscular male. You can feel the edge of the muscle or see the edge of the muscle. It's a line called a semilunar line. It extends inferiorly right alongside the lateral edge of rectus muscle. This is the anterior rectus sheath, which is typically white, shiny fascia. There's still a little bit of fat on top. Let's see if I can make that a little better. If you notice on some of the other podcasts that the fascia is typically removed from the muscle to demonstrate the muscle a little better, I'm leaving the fascia. Surgeons love fascia. And the reason that surgeons love fascia is that fascia holds sutures. Muscle does not hold sutures very well, so if you're closing an abdominal incision, you want some good stout fascia to use to close. I think you can see this a little bit better. This is our rectus sheath here. Rectus muscle is under it. Remember up here we came across rectus muscle and I showed you how the anterior and the posterior rectus sheath were formed. Here's where the umbilicus was, and there's really not much there to show you in this adult. So I'm not going to be able to show you much in the way of anatomy there. if I carry this incision, this midline incision down a little bit more deeply, let me do this. Let me extend this across the midline and see if I can demonstrate the linea alba to you. I'm just going to take some of this same tissue a little bit across the midline there. There's a place where the fascia comes together on both sides, and it's called the linea alba. And it's actually quite wide in the upper abdomen. It's almost like a band of tissue rather than a line of tissue. And you can feel it again if you feel the medial edge of rectus muscle is right here. Here's the opposite rectus muscle coming across there. And right between there, it looks like his midline is a little bit more to the left of his xiphoid process. So I'm going to just make an incision here between the two rectus muscles, and let's see what I find. And I do indeed have linea alba. You see there's no muscle there. It's just a band of fascia in the midline of the abdomen, so that would be called the linea alba. And typically for a midline incision, we make the incision all the way down the abdomen, again going around to the left of the umbilicus, and then down the inferior midline. Looks like I got a little bit to the right of the midline there, got into the muscle a little bit. Let's see if I can get back into the midline. Sometimes the midline is very indistinct in the lower abdomen, but there is a structure I wanted to show you inside here. If I can demonstrate it. If you notice up here, we have good thick fascia in the upper part of the abdomen, the posterior rectus sheath. Down in the lower part of the abdomen, we don't have much in the way of fascia at all. That's because in the lower part of the abdomen, all those fibers from the aponeuroses of the abdominal muscles pass anterior to the rectus muscle, and none pass posterior to the rectus muscle. So you don't have a posterior rectus sheath in the lower abdomen. Sometimes you can see a distinct demarcation where the rectus sheath stops, and that distinct area of demarcation is called the arcuate line. In this patient, it doesn't demonstrate an arcuate line very well, but it does demonstrate some other structures. I don't know if you can see it very well, but there's a line inside the abdomen. I'm not going to be able to show it to you, that extends from the area of the iliac arteries up to the umbilicus, and that's the obliterated umbilical artery. And that other structure I told you about before that's just to the right of midline is the obliterated umbilical vein, which extends from the umbilicus proximally into this structure, which is called the ligamentum teres. And the ligamentum teres goes proximally all the way up to the liver. The liver is right here. So the umbilical, that's where the umbilical vein returns circulation through the liver to the inferior vena cava and then to the heart. And I think probably that's all we're going to do today.